First of all, the emergence of new data sets, both as population-level data is aggregated, but also publicly available data sets as they become available, encourages innovators to develop new ways to analyze and make that information more personable. The decline of operational expense is something I really want to point out. In this day and age, with the emergence of cloud technology, you can start a business where a lot of the administrative processes of collecting that data, a lot of the analysis is able to be achieved at pennies on the dollar of what it used to take to run or initiate a startup. So I can put together an organization, or I've seen, novel innovators develop organizations that are completely cloud-based, where all you have is an application that's sold on a mobile platform. You can collect data, analyze it, and put it out. And the operational expenses is rather small compared to what existed not 5 years ago. New application platforms. Who hasn't heard of the iPhone App Store? Okay. Has helped to, encourage this development. Certainly the Microsoft Health Vault platform, which I'm sure many of you are familiar with, has encouraged a good deal of innovation, because it really focuses the innovator on developing a very narrow and strategic piece of what they're trying to achieve. Strong stakeholder engagement from a large number of institutions, the payer side, pharmaceutical industry, pharmacies. They're rapidly, turning to health IT as really a vehicle for achieving their overall organizational mission, but also, experimenting with new conduits to expand their markets. And finally, federal policy. I would argue that a lot of the attention that has been paid to health IT on the clinical side is engendering a good deal of innovation on the consumer and patient side, recognizing that one day those two worlds will overlap to a great deal. What form that will take remains to be seen, but we're currently seeing a good deal of excitement on the innovation side, really to develop new business models and to improve clinical outcomes at more efficient levels. So let me end here, okay, and we'll look forward to your questions at the end of this presentation.
I'm feeling a little lonely. I'm a doctor. I actually see patients. I've had the same panel of patients for 40 years. I'm also a teacher, and I'm a researcher. As a teacher, I'd love the rest of you to come over there so you can see my slides, because otherwise you'll all go to sleep as your splanchnic circulation gathers luncheon more actively. So it might be helpful to you if you can. I don't know. Let me be much more concrete in terms of one specific activity that grows on everything I can say yes to from the people on both sides of me. I came to this consumer business by being a doctor and by being a patient and by very early on wondering what the patient experience was. In fact, David Blumenthal, when he was a medical student, to date me, and I taught a course in the early 70s about taking Harvard medical students around to see the haves and the have-nots and what their experiences were. And we went to Metropolitan State Hospital and McLean Hospital the same day to show what a state hospital was like and to show what a hospital for the rich and crazy was like. Then I guess I'm guilty for being one of the people that coined this awful term patient-centered. I don't like it. Because doctors, nurses, everyone in the profession feels that he or she is patient-centered. And by throwing it in everybody's face, it implies that we're not doing what we like to do. In fact, I've had a standing offer of a case of wine to any of you and anyone listening for a better term, but it seems to have stuck. We started it in the 80s when we started something called the Picker Institute, which tried to learn from patients and listen to them and call on patients to serve as expert witnesses to what we did. I've also long thought, as a decidedly non-computernik, that the medical record was the place to convene and bring people together. And in fact, 30 years ago, I did a little experiment in which we had patients walking around our hospital carrying their records with them and saying to their doctors, okay, you write down what you think, I'll write down what I think, and then maybe we can get it together. And that experiment, we wrote it up, but the experiment ended after about 6 or 7 visits when an ENT doctor, being asked to write down what he thought and have the same thing, thought the patient was psychotic and wanted to suggest a psychiatric consult for that patient. So times have changed since then, and now it's fashionable. And we still don't really understand as much as we need to, or we don't even begin to understand in these Model T stages of everything that Will and Alice are expressing, hoping for, and showing what will happen. So we're doing an experiment, which I hope will interest you, and which I will share with you. And we call it Open Notes. The basic notion is to increase patient engagement and to play with this word transparency. You know, if you don't use the word transparency in every third sentence these days, you're certainly not going to get a grant or get anyone to listen to you. So we brought it in here too, but there is a certain importance to the meaning. A lot of people are trying to increase patient engagement in promoting their health and managing their illness. And at many of the fortunate institutions, mine being one of them, patients can actually now view their laboratory results, their medication lists, and other parts of their records online. But the fact is that while everyone sitting in this room has legal access to his or her patient record, it's not easy to get it, to put it very mildly. You all can give me anecdotes about that. And it's certainly true that we clinicians do not typically share our visit notes with those whom we serve. So we're doing an experiment. We got a nice grant from the Johnson people and another fund, the Grain Family Fund, and we're doing a 12-month experiment, which I'm going to describe to you now, and I'm going to challenge you to tell me some of the results. We've got more than 100 primary care doctors and more than 21,000 patients in Boston, both at our hospital and in urban related practices in the inner city and in suburbia. In rural Pennsylvania, with the Geisinger Health System, which is very rural and which is middle class and not so middle class, and some wealthy people scattered all through the state. And in the inner city in Seattle at Harborview, which serves the medically indigent and the socioeconomically indigent. And we're all doing the same thing. We're inviting patients to read what we write about them after they see us. And how are we evaluating our experiment? Well, we're surveying patients, both those whose doctors are participating and those whose doctors who politely decline to participate on a voluntary basis in this experiment. And we're serving them before. What do you expect? What do you hope for? What do you think may happen? What do you anticipate will come out of this? And then after the year-long intervention, we'll go back to the doctors and the patients and say, so what happened? Did it mean anything to you? Did it change your lives? Did it do anything? Was it a lot of fuss about nothing? What do you think? We're also analyzing the way people practice, practice patterns that they may change, the activities of the patients, and we're gathering together an enormous database, which I don't begin to understand, but which my colleagues who know how to count things will teach me about as we move forward. And we're also gathering anecdotes, both from patients and from doctors, because even though in academia you're supposed to publish things with p-values all the time, qualitative research and the words of 1 or 2 or 3 patients can be at least as insightful and meaningful, I think, as sometimes the aggregate data that none of us really trust, but that we present in order to get another grant. We did publish a paper in the Annals of Internal Medicine kind of speculating about this issue, talking about the various uses of the medical record and the patient portal, and those of you who might like to look at that, do so. Our hypothesis going into this study is that we would indeed enhance patient-doctor communication. once both recover from the initial shock of what's happening. We may well reduce the likelihood of litigation by increasing accuracy among the doctor's notes. And we hope and we hypothesize that we may increase patient activation, promote shared decision-making, satisfaction with care, some of the things that Alice outlined and some of the things that Will is certainly pointing to. The question is, for doctors, these are a few questions. For example, will open notes prove to be a burden, particularly at the start? Will it make doctors spend more time worrying about and editing their notes? Will it lead doctors to change the content of what they write or dictate in their notes? And for patients, will patients actually read their notes? I guarantee you that some will and some won't. Will they share them with others? A very interesting question to me, and we'll come back to that. What will they do with them? Where will they go? Will I begin to get emails saying, Dr. Baker over there thinks I should do this. Do you think he's right? And then will I be sending an email to David in Chicago saying, you're a really good guy, we're in the same business, but I really think you're off track with this patient. And how do you like that, David? And that will produce another dialogue. So will the patients share their notes with their doctors, with their doctor friends, their cousins, the lawyer, their loved ones, the New York Times? We don't know. One of the interesting things about patient portals that Jan Walker, my colleague in this, points out is that the doctor-patient relationship is sacrosanct in its confidentiality, right? Everyone nods their head and everyone tries to maintain that. But the fact is that privacy with an intervention like this is entirely up to the patient. The patient may decide to unload this and disseminate it as a textbook of how not to do business or how to do business or what have you. Privacy will therefore be in the control of what I'm learning to call consumers or patients. Never quite know what to do, maybe people, as they move ahead with this. So whom have we, will patients find these notes helpful or will they find them confusing? Will they actually become more active in their care? So what we've done first is we've surveyed the patients who are eligible to participate and the doctors. And we've talked to an awful lot of them. We have 174 doctors responding to these surveys about expectations. And we have just finished analyzing 38,325 surveys from patients, believe it or not, answering these questions. One of the fascinating things is a response rate of 42% is enormous. If you think about just getting an email out of the blue saying, hey, would you like to complete a questionnaire on such and such? You know what you do when you get a call or something like that. You go click, delete, or click, don't call me again. 42%, 2 out of 5 people answered this very simple question. It shows the fascination, the interest, the things that Alice was pointing to, the things that Will shows among people about healthcare and issues like that. Who do we talk to? Well, we have a lot of different people. The mean age is 50. 3 out of 4 are women. 3 out of 5. Most of our patients are white, but with a sample of 38,000, we can look at all kinds of patients from all kinds of backgrounds, and we will. 2/3 of them are work. We have a wonderful spread of education. More than 25% have less than a high school education. 29% went to college, and we've got all the way up to some eggheads who've had more than post-college college graduation.